All right, so let's talk about what is dementia, because I haven't answered that basic question. Most of you at this point in time across the nation, if I say the word dementia, the very next word that will jump right into your brain is Alzheimer's. And then if I say, well, okay, what comes next? Memory problems. So I want you to have on your brain right now a whiteboard or blackboard, whichever you like, and I want you to write dementia, Alzheimer's, memory problems. I want you to write it on that blackboard, and now I want you to go erase it. Erase it. Go ahead, take your hand, erase it. Take it off. And I want you to write dementia equals brain failure. Because you got to quit thinking about memory problems. That's not what it is. This is brain failure. And it's not all about Alzheimer's. That's where we're making our big mistake. We think about Alzheimer's and we think we know it all. Here's what we know. Dementia is a great big umbrella term. It is a huge umbrella term. It covers about 80 to 90 different conditions. There are about 80 to 90 different forms, causes, and types of this thing called dementia. When we say someone has dementia and they've actually gotten a good evaluation, now let me say that again. When we say they have dementia and they've actually gotten a good evaluation, put up 10 fingers. Let me show you something right now. Take down all but 2. At this point in time, only 2 out of 10 elders will get a good evaluation. They'll get a real too quick, not a good evaluation. They'll get a little screening thing. That is not what should be happening, but it is what is happening across this nation way too often. A 12-minute office visit, and what's the day, what's the date, what's the day of the week, what's the month, what's the season, what's the year, what's the name of this place, what floor are we on, what city, what county, what state. I'm going to give you 3 words. I want you to try to remember to hold on to those 3 words. This is really important. Ball, flag, 22. What were the 3 words I asked you to remember? Okay, now I'm going to try to trick you. Now, have 100, take away 7, take away 7, take away 7, take away 7, take away 7. If you can't do that, can you spell the word world backwards? Say this, no ifs, ands, or buts. Take this piece of paper, fold it in half, and put it on the floor. Okay? Read this and do what it says. It says close your eyes. Write a sentence. Draw 2 intersecting pentagrams. What are those 3 words I asked you to remember? What's this and what's this? Ta-da! Pass it, you don't have Alzheimer's. Fail it, you do. Now, here's the problem with that. Some people who are really smart can pass that, and they have Alzheimer's. The other thing is you can be really dumb and fail it and not have Alzheimer's. You're just really dumb. I mean, you're not real smart. And unfortunately, this was developed over 30 years ago, back when I was getting started, and it was meant to be used as a screening tool to determine whether somebody might have something going on that we should look at more closely. What happened is researchers started using it as a sort of a separator for between people who were normal and people who were showing signs of something else. And then doctors recently started using it. If you don't score well, they start you on Aricept. And it's like, whoa, wait a minute. It shouldn't be like an assessment tool. It was never designed that way. It's not very good that way. What it should be is a screening tool. The problem is it takes about 20 minutes, and most doctor's office visits from beginning to end are about 12 to 15. So that's a problem. Okay, that's a problem. Currently, in most physicians' offices, the most current screening that is done, you ready for what the screening for cognition is in your doctor's office? When I say screening, tell me what you do every time you go to the doctor's office. What's something you have to do every time? Blood pressure? Weight, yeah, you get on the scale. You got it. Your name and your birthday. Yeah, most of you know that one pretty well, unfortunately, pretty far. Here's the most current screening on dementia, if they do any at all. How's your memory, John?
Pretty good.
Great. How's your heart?
It's okay.
Let me check it. Let me check it. That's it. Most physicians' offices, that's as far as screening goes. Now, let's say John's concerned. Okay. How's your memory, John?
Terrible.
Well, John, you know, you're 82. What do you expect? And on we go. I mean, the problem is, no matter what you say, you get dissed often. Sometimes they'll say, well, you know, if you're worried about it, you don't have it.
Well, my 10-year-old friend would say that sucks.
Yeah, that sucks. I know, it does suck, because it shouldn't be that way, and yet it is. That's what we're seeing right now, and that's what's got to stop. That's why we're talking about early identification. Because if you do early identification, you can start to make ideas and plans work. But if you don't even know what you're dealing with it for about 5 years. Because right now it's mid-stage dementia when you get your diagnosis. By then, you're in major trouble with money. You're in major trouble with meds. You may actually not even have dementia. Because dementia is this. There are 4 things that are true about all dementias. These are the 4 characteristics of all dementias. Number 1, the first thing that's true, at least 2 parts of your brain are dying, maybe more. One of them is somehow related to memory, but it's not always new information versus old. It can be delusional thinking. And certain dementias, it's not necessarily a memory problem as much as it is a misremembering. So I misremember information. I don't not remember it, I misremember it. The second characteristic is true about all dementias. All dementias are chronic. There's no way to fix them. We do everything we can to fix the situation. We may make some things better, but this is actually changes in the brain, so this is not getting better. You can't even stop it where it's at. Its third characteristic, it's progressive. All dementias get worse. It's a question of how they get worse. And each dementia has its own pattern, its own system of doing that. But all these dementias, every real dementia gets worse. The fourth thing that is true about all dementias, they're all terminal. They all kill you. They all kill you. Now, the things that look like dementias but are not are called pseudodementias. It can include delirium that you might have while you're at the hospital, or when you take a medication that doesn't agree with you, or when you get dehydrated, or because you've had a little stroke that maybe turns around and you get back to where you were. A delirium is a short-term, very acute thing. The other pseudodementia is depression. And depression is treatable if we catch it and manage it and treat it, but it's complicated. And here's the bad news. These 3 Ds like to hang out together. They like each other. So we did a recent study where we found out that people who showed delirium in the hospital at some point over the age of 65, within 2 years, 50% of them had developed full-blown dementia, even though they didn't have it identified at the time. It's a sign of a vulnerable brain. Anesthesia in older adults, very dicey thing. It doesn't work well for everybody. Okay? So we want to be thoughtful about that kind of thing, but they're related. So dementia, great big umbrella term. Notice the biggest box under there, Alzheimer's. 10 years ago, we were thinking that it was about 80 to 90% of all dementias. Not so anymore. Current thinking, about 50 to 60% of all dementias are straight out Alzheimer's. The rest are Alzheimer's plus another dementia or another dementia entirely. You can have dementia and not have Alzheimer's. If you've been identified as having dementia, you don't have a diagnosis. All you have is a syndrome, a collection of symptoms. It's not until we get under that umbrella that we know what kind and sort and form of dementia you're living with. So the most common Alzheimer's, 2 forms that we know about, young onset and what's now being called late onset. Young onset, we used to call it early onset, but it got confusing because everybody goes through an early stage. Young onset refers to people who show first symptoms before 65. And we have a new young age, 25. We have a 25-year-old who's in mid-stage Alzheimer's already. There are certain genetics. This one is tightly, often genetically linked, but there are some young onsets that are not genetically linked. It's just an abnormality that occurs with that person, but it doesn't run in their family. There are genotypes, however, that do occur with young onset. So it runs in families often with young onset. The risk is higher, but it's not absolute. We also know that people with Down syndrome are actually born with a 3rd chromosome, 21, and the Alzheimer's stuff starts forming. The beta-amyloid plaque, the tau protein, starts forming at birth. And so they have premature Alzheimer's. Often by the age of 35 to 55, people with Downs will be showing signs of the disease, pretty significant signs. And the problem is, up until very recently, those folks didn't make it to adulthood. They died in their teens and early 20s. So this is our first generation of people with Downs who are now reaching full maturity at 35 to 55. And the numbers of people with Downs developing dementia is rising rapidly. Okay? Now, the normal onset, quote unquote, which is now called late onset, I need to change that slide. It should be changed, and it is not. Late onset is the kind of dementia that most of you are more familiar with. It starts after the age of 65. Okay, at 65, if everybody in this room, we were all 65, if I could get these first 3 rows to stand up. Yeah, maybe the 4th row too. I'm going to be generous. 4th row. This many of us at 65 in a group this large would have dementia, Alzheimer's type. How are we feeling about them? Aw, that's too bad. But could we pull it together and care for them? Yeah, I mean, if we needed to, we could deal with it. We feel bad for them. Here's the trick. By age 85, we're all now 85. Everybody on this side of my arm stand up. How are y'all feeling over here? Oh my Lord. Because at age 85, we're talking about almost 50% of people 85 years of age will show the symptoms of this disease. So guess when we're not looking for this and we're not paying attention to it, we're not even assessing or screening for it, guess what's happening to us? We're being overwhelmed by this, and the numbers are going up. You can have a seat. As Carol said, the baby boomers are hitting, and they're starting to turn 65. Well, at 65, it's not so bad, but what happens when they turn 85? Yikes! And many of you, if you haven't figured it out yet, you may end up with a twofer. A twofer is where your mom's taking care of your dad, and then sometime you realize, well, shit. Mom is not doing what I've told her to do. I mean, I keep telling her, she keeps giving him the wrong medicine. My Lord, how many times are we going to do this? Mom, I told you what? Did you tell me? I told you. And you think, oh, well, it's just the stress of caregiving. It might be, but it might not be, because both of them are now over 85. And this is that nasty surprise that sometimes you figure out. It's like the reason mom's not doing what you asked her to do is that mom can't do it like you asked her to because she can't hold on to it. And she's going to be labeled as non-compliant and non-cooperative, and that's not what she is. She's doing the best she can with what she has left. But she can only do things the way she's always done them. She can't switch up and do something different. Not because she doesn't want to, but because her brain is dying. Okay? Now we have all these other dementias. I'm not going to be able to go into them today, but you do need to learn about them because the person you care about might not have Alzheimer's. Now with Alzheimer's, oh Lord, guess what it's telling me? I only have a half hour before we are going to answer questions, which is fine, but I've got a lot to get through in half an hour. Get ready. Fasten your seatbelts because we're going to get cooking now. Vascular dementia, second most common type of dementia we think. It has to do with the blood supply to your brain. It's not a brain disease. Alzheimer's is a brain disease. Vascular is not. It's a blood supply to the brain problem. So people who've had heart attacks, people who've had strokes, people who have cardiovascular disease, people who have diabetes, people who have peripheral vascular disease, people who have microcirculation problems in their brain. The old term, atherosclerosis. Grandma's got the hardening of the arteries. There you go. We used to think we went in there and roto-rooted those babies out and our arterectomies, we could clear it out. We made it worse. So what we know is vascular dementia can stay the same for a long period of time and then have sudden changes. So they don't change all the time. They stay the same, and then there's a sudden, whoo, wow, man, what's going on? I can also tell you that certain parts of their brain may be fine while other parts are damaged. Alzheimer's, it spreads. Vascular, it's different. One of the hallmarks of vascular, however, is emotional issues. Okay, so let me show you what it looks like with, this is one you do want to know, vascular. Okay. Hey, sweetheart, how are you?
Just fine. How are you?
I don't know. That is the classic call and respond of a vascular dementia with emotional lability. In other words, they're labile emotionally. It goes out of control in a heartbeat. She asked me a simple question, how are you? And I fell apart. I started weeping. I started giggling, whatever it was, and it was like, why? Why are you doing that? What's wrong? That's the most common thing you're going to say, and I'll say, I don't know. And the more you try to comfort me, the worse I'll get. This is the one where you say, Teepa, I'll be right back. Go grab Kleenex, get my favorite thing to drink. Here, blow your nose. Here, I got your coffee. And you're thinking, that seems mean. It isn't, because it's not a choice of the person. The part of your brain that's affected here is the emotional control center. It's very vulnerable to vascular damage. So they get really emotional about things, and it seems to come out of nowhere, and they can't bring it back under control unless you just stop and start over. So when you tell this, you say to this person, let's take a shower, and they go, no, 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 stop. You're not going to talk them into it. You need to back off completely, start with something different, don't pay any attention to it for a little bit, and then come back to it later. The other thing you might see is called apathy, flat affect. They don't care. It's one of the hardest things to deal with when this person has always been engaged and active and wants to do things, and they are fine sitting in a chair for hours, doing nothing in front of the TV. And you say, well, come on, let's go. Not now. Come on, let's just do it. No, I don't want to. Come on, Daddy, let's get up. I'll go later. Dad, please. I told you no. How about something to eat? We'll bring it here. And you feel like you care more than they do. And it's not that they don't want to care, it's that they can't. And it's really hard to deal with that. It's a very difficult one to deal with. With Alzheimer's, let me go back to that. Alzheimer's average length of life from first symptom to end of life, 8 to 12 years. 8 to 12 years from the very first symptom appearance, which you're going to miss until you look back, to the end of life of about 8 to 12 years. With vascular dementia, are you ready? 3 to 30. Totally unpredictable because it's not a brain disease, it's a blood supply problem. So whatever affects the blood supply, so they could go tomorrow or they could be that way for a long period of time. Some people with vascular dementia, you're noticing everybody else around is changing but them, and then suddenly, boom, they're different. But you can't tell what's going to happen next or how quickly. The next one I want to mention, Lewy Body. Lewy Body is the most missed as a diagnosis and the most misdiagnosed. It's misdiagnosed as Parkinson's, and it's missed as a diagnosis completely. Lewy Body is probably one of the most stressful caregiving situations you will ever come across because Lewy Body dementia, Lewy Body's synuclein abnormal protein formations over the cortex, the surface of the brain. First symptoms, falls. They fall like crazy. It's like they're falling, fall, and then the falls go away and they're fine. And when they work them up, they can't find anything that's causing the falls. So they think, okay, well, maybe Parkinson's. But then it doesn't necessarily work out. The other thing that's classic symptom of this is hallucinations, visual hallucinations. Worse in the afternoon and evening than during the day. And it's, look, you see that little boy? The one right there. Go tell him to get out of that tree. Right there. Tell him to get out of the tree right now. Get out of that tree, little, huh? Well, no, look here. Get that dog out of here. Get him out here. Come here. Animals, children, or people, they see them just as clearly, and they can tell you about them. And you trying to argue them out of it won't do you a bit of good. It's visual more than anything else, and it's animals, children, or people, and often dangerous situations or scary situations. The other thing they will have at Parkinson's, and this is sort of one of the symptoms. Now, don't expect all the doctors to know this stuff, because they don't keep up with it. With Parkinson's, what you're going to see is called a resting tremor. They tremor when they're not trying to do anything, and then when they go to do it, it goes away. Lewy Body, not a resting tremor most frequently, but when they try to do shit. Oh my God. Why did you trip me? Why did you trip me? I saw you stick your foot out there. We'll report him to the damn police. I have misremembering of how things happen, but in my brain is absolutely sure that he stuck his foot out and tripped me. Is that what happened? But I can tell you what I had for lunch and I'm right. That's a problem because with Alzheimer's, you're going to go, they wouldn't know lunch. And it's right, they wouldn't, but I do. That's why knowing the different dementias really matters. So, now, we could talk more about all these. Look at this, 80 to 90 of them. 80 to 90. I wanted to point out Lewy Body, and I also will mention frontal temporal dementias. When we get into talking about the brain, you will have a better handle on frontal temporal. What does that mean? Front part of your brain, temporal part. When I talk about the brain, that'll help you out. But we also have genetic diseases, things like Huntington's, Creutzfeldt-Jacobs. We have metabolic problems. People with diabetes have a high risk of developing dementia, very high risk. We know that alcohol-related dementia exists. People who drink a lot of alcohol kill brain cells. And when that happens, they have Korsakoff syndrome. That's a particular type of dementia. You can also have other drugs or toxin exposure. People who've had breast cancer and had tamoxifen in large doses, we're starting to notice about 5 to 15 years out. They never survived before. Now they're surviving. We're starting to see memory issues coming up. We're starting to see cognitive issues starting to come up. And at first people were going, you're just getting into the menopause thing. It's just that. And now what we're finding out is, no, it maybe isn't just that. It's more than that. We also know that people with MS develop dementia at about 40% of people with MS. We know that people who have Parkinson's disease, which is different than Lewy body, people with Parkinson's will develop dementia in about 40% of cases, usually about 5 to 8 years after the start of their Parkinson's symptoms, movement problems, but not so much the falls at first. We also know that people with depression or other mental health issues are much more prone to develop dementia at a younger age. The risk goes up by about 50%. Told you those guys like to hang out together. So what we're looking at here is you can have more than one of these. That's called mixed picture. You can have an atypical dementia. What we want to do, if I'm going to care for somebody, doctors are going to say, well, what does it matter? From their point of view, it doesn't as much because they don't really have a lot to offer medication-wise that would be different one over the other. To us, it really does matter because what you're going to be able to do and what you're not going to be able to do is highly dependent on what type of dementia you start with. As we get further into the disease, it may matter less, but early on, it really does matter what type of dementia. It's not one size fits all anymore. We really do want to know more about this.